Hello, welcome. My name is Arif Khwaja. I'm a nephrologist at the Sheffield Kidney Institute, and welcome to this lecture on malignancy and kidney transplantation. Malignancy is obviously an important cause of morbidity and mortality after transplantation, and it's impossible to cover the whole gamut of, if you like, presentations of malignancy after transplantation. So what I'm going to do in the lecture for the next 20 minutes or half an hour or so is focus on the following key points. I'm going to just talk a little bit about the epidemiology of cancer in solid organ transplant patients. Very briefly mention the pathogenesis of such cancer, talking about the role of certain viruses and particular kinds of cancer and the role of immunosuppression. And then I'm going to focus on two particular cancers, post-transplant lymphoproliferative disease or PTLD, and then skin cancers and skin disease post-transplantation. So the first thing to say is that cancer risk is significantly increased in transplantation. There's roughly a 2 to 4-fold increased risk of cancer, and the spectrum of cancers is diverse. It can be anything from PTLD to lung cancer, liver cancer, skin cancer, kidney cancer. And 43% of cancers are comprised really of PTLD, lung, liver and kidney cancers. And the risk can be very high, particularly if you look at kidney cancer. In kidney transplant recipients, the risk of cancer in the transplanted kidney is 100 times greater than that which we would expect. And if you look at this data from the United States, this is the SRTR database, which is the scientific registry of transplant recipients. It's a large database, and what they did here is they linked the transplant database registry to the cancer registry to identify the risks and the pattern of cancer in transplant patients. And what I've highlighted here in the red box are those patients who've undergone a kidney transplant. And you can see there's a 6-fold increased risk of non-Hodgkin's lymphoma, a 1.5 times increased risk of lung cancer, liver cancer broadly the same as the general population, but a 6-time increase in the risk of kidney cancer. So clearly the pattern of cancer varies with the organ transplanted. So liver patients are much more likely to, for example, to get liver cancer, while kidney patients are much more likely to get kidney cancer. And the age at which you're transplanted is also important, so that those who are transplanted at a younger age have a relatively higher risk of getting a cancer than those who are transplanted at an older age. And the cancers present at different timelines. Kaposis sarcoma may present in the first couple of years. Lymphoma, the sort of usually may present in year 2 or year 3, but the risk is high very early on if you get a primary infection with Epstein-Barr virus, and the risk of lymphoma increases, and I'll show you that in a short while. Skin cancers can happen at 5 to 6 years or earlier, and anal and genital cancers occur much later. Okay, so why do transplant patients get cancer? Well, very simply, the immunosuppressive therapy really causes impaired immune surveillance of neoplastic cells. There is some evidence to suggest, mainly predominantly in vitro evidence, and it's not hard evidence, that the transplant medication itself, the immunosuppressant medication, has a direct oncogenic effect, but I think the evidence for that is less so, and the assumption is that this is all impaired surveillance. On top of that, you've got increased risk to sort of certain carcinogens, such as obviously sun in the context of skin cancer. And then there are a whole load of host factors which may increase the risk of cancer: how long you've been on dialysis, whether you're exposed to certain viral infections. So, for example, EBV, Epstein-Barr virus, is strongly associated with PTLD, or post-transplant lymphoproliferative disease, while HHV8 virus, the herpes 8 virus, human herpes 8 virus, is strongly associated with the development of Kaposis sarcoma. So if we look at the risk factors, the skin cancer, the amount of sun you're exposed to, the skin type. If we look at immunosuppression, Belatacept, which is a co-stimulatory blocker, is particularly associated with PTLD, particularly if patients who are EBV negative get an EBV positive kidney or develop EBV infection. They're at much higher risk. And then patients that are given T lymphocyte depleting medications such as ATG or AKT3 are much higher risk of PTLD. And CNIs, again, probably through impaired immune surveillance, increase the risk of cancer. Azathioprine may have a specific association with squamous cell cancers of the skin because they may inhibit DNA repair. There's some sort of in vitro evidence for that. Sirolimus is generally thought to have an anti-cancer effect, and we'll talk about that later, but mainly through its effect on inhibiting cell proliferation and lymphangiogenesis. And MMF, there's some suggestion it may reduce the cancer risk predominantly through reducing the risk of acute rejection, thereby reducing the risk of heavy-duty immunosuppression. So what the viruses, we've all talked about EBV virus being associated with PTLD, human herpes A virus associated with Kaposis sarcoma, and this is very common in the Mediterranean and the Middle East. Squamous cell cancers and cervical cancers may be associated with human papillomavirus. Merkel cell cancer will be associated with, misspelled papilloma there. Merkel cell cancer can be associated with Merkel cell polyomavirus, and obviously hepatitis B and C in the context of liver transplantation or in kidney transplant patients who've got hepatitis B and C are at much higher risk of developing hepatocellular carcinoma. Okay, another risk factor is obviously the donor may transmit the cancer. That's usually quite rare, and a prior history of malignancy may increase the risk. And the usual policy is that one would wait 5 years before listing, but it clearly would depend on the tumour type. So if there is an incidental basal cell cancer, then obviously that won't delay listing. Similarly, if somebody has a renal cell cancer that's very well localised, small and hasn't spread, then you may elect to wait shorter than 5 years before transplanting. How do you manage cancer post-transplantation? Well, clearly it depends on the type of cancer, but the general principles are: one is to reduce immunosuppression. There's always this question about whether we should stop the CNI or replace the CNI with Sirolimus, and I'll talk a little bit about that later, but it's important to say that really the evidence that Sirolimus actually improves outcomes in cancer patients is really, in context of transplantation, is really limited to skin cancers, and outside that we don't know whether Sirolimus has a clinically significant anti-tumour effect. Sirolimus seems to have a particular benefit, as I say, in skin cancers, but also in Kaposis sarcoma. And when it comes to PTLD, the sort of general principle has been to eradicate the EBV, although as we'll talk about that later, the efficacy of that is doubtful. Perhaps give rituximab, radiotherapy or chemotherapy. So again, the treatment really depends on the underlying cancer, and we're always guided by the specialist, the haematologist, the dermatologist, in terms of how to manage that cancer. Okay, so let's just talk a bit about PTLD in a bit more detail. Clinically, it presents as any lymphoma does, so it may present with constitutional symptoms of weight loss, malaise, fever, and an infectious mononucleosis type of infection may be present, and that may indicate primary EBV infection. You may have nodal masses with lymphadenopathy, and interestingly, in the transplant population, CNS involvement is much more common than the general population. Some lab features: most PTLD is associated with EBV virus, so you may have most patients will be EBV positive when you test their blood. There may also be evidence of pancytopenia, elevated LDH and CRP, raised calcium, and perhaps raised uric acid level. And the diagnosis will be made by biopsying the lymph node. And if we look at some registry data, this is registry data from France, which is very big. It has sort of collected a data on a large number of patients, what you can see is a couple of quite interesting kind of phenomena here. Firstly, that the cumulative incidence of PTLD increases as the time after transplant increases, and this probably just reflects your cumulative immunosuppressive load. And secondly, that perhaps the incidence of PTLD is declining in the more recent era compared to the earlier era of transplantation. So that's 1998 to 2001 was a bit more common than the more recent era of 2002 to 2005, and that probably reflects the fact that well, it may reflect a number of things, but it may simply be that there's less acute rejection in the more recent era, and therefore less need for heavier immunosuppression. So maybe the immunosuppressive burden may be less, but it may also mean that we're better at diagnosing, better at preventing PTLD. So it's strongly associated. PTLD is strongly associated with EBV infection, and if you look at this data from the US SRTR database, you can see that patients who are EBV seropositive are a much higher risk, this in the dark grey here, of developing PTLD than those who are EBV negative, whether they're having a kidney transplant, a heart transplant or a liver transplant. And if we go back to the French registry data and look at the location of PTLD, you can see it occurs in the GI tract, quite common in the brain, much commoner than the general population, that's in the blue line, but also often occurs in the kidney graft as well. And if we look at the risk factors, if you like, for the time to onset of PTLD, well, there are a number of risk factors, but as we said, giving ATG or OKT3 is associated with higher risk. If you're EBV negative, then that's at the time of transplantation, then that's associated with a high risk because you can then develop EBV infection, and similarly age at the time of transplantation may also be, or age may also be associated with a higher risk of PTLD. So those who are older are perhaps more likely to get it than those who are younger, or in terms of time to onset of the disease. And similarly, the transplant era, as we said before, the earlier eras were more, PTLD seems to be more common than in the more recent eras. So, as I say, PTLD is commonly associated with EBV infection or reactivation. Most adults will have had a primary EBV infection, which causes, as you know, flu-like illness, and the virus remains latent in B lymphocytes. Immunosuppression will inhibit the cytotoxic T cell response, causing EBV cells to proliferate, and that leads to sort of clonal expansion and malignant transformation of EBVs, of B cells. And that's this diagram here just kind of highlights what I've just said. The immunosuppression allows B cells to proliferate and allows the virus to replicate, the virus that's perhaps latent in the B cells to replicate, and this may cause genetic mutations and malignant transformations within the B cell, causing it to sort of replicate in an uncontrolled manner. So one of the questions that's being raised is whether we should monitor EBV routinely post-transplantation. I think the consensus opinion is that if you are EBV negative, then it would be sensible to monitor EBV PCR routinely post-transplantation, certainly in the first year or so. But this is quite a nice recent paper published from Manchester in the United Kingdom, and this is a study of 499 patients who were repeatedly tested for EBV in the blood post-transplantation. And what they found, they looked at the patients who were enrolled in the study and compared them to patients who weren't enrolled in the study. And what they found was something relatively interesting. First of all, that those patients who had EBV detectable had a slightly worse, although not marginal, not really statistically significantly worse survival, and were more likely to, sorry, these are patients who have EBV who aren't, these are patients, I'll start again. So this graph here shows patient survival, and this graph here, PAL-C, shows freedom from PTLD, and patients in whom EBV is undetectable at baseline, you can see they are much more likely to survive than patients who have EBV. And that makes sense, doesn't it? You get an EBV infection, or you have EBV viremia, and that's associated with PTLD. So much people with EBV viremia, detectable EBV viremia, have slightly worse survival, although not statistically significant, but are less likely to be free from PTLD, just marginally significant. However, if you look at patients who had this systematic monitoring, these are panels A and D, you can see patient survival was no different, and freedom from PTLD wasn't different, although there was a suggestion that it may be becoming significant. It wasn't significantly different. So quite reasonably, I think what the authors conclude is that EBV DNA, or detecting EBV viremia, has poor EBV viremia is really, or EBV DNA is really a poor biomarker for PTLD, particularly in low-risk patients, so patients who are already seropositive. In seronegative patients, who are seronegative at the time of transplant, then monitoring for EBV may be useful. But if you're seropositive at the time of transplant, monitoring EBV DNA to predict who's going to develop PTLD doesn't seem to be particularly effective when compared to just not monitoring patients at all in improving outcomes. So what are the histological classification of PTLD? Well, this is really mainly for the hematologist, but you can have early lesions where you have a plasmacytic hyperplasia and an infectious mononucleosis type picture in the lymph nodes. Sorry, misspelled lymphoid there, but you may have lymphoid proliferation, but the architecture is normal. Then you can have polymorphic PTLD, where you have a pleomorphic children infiltrate and the tumour cells will contain EBV. Monomorphic PTLD, where you have a malignant clone of B and T cells, or cells of B and T cell origin. And then finally you can have overt Hodgkin's lymphoma. In terms of the treatment approaches, I think that there are three aspects to treatment. One is to restore the patient's immunity, and that's by and large done by reducing immunosuppression. That may be by reducing or stopping the CNI, or reducing or stopping the antimetabolites such as azathioprine or mycophenolate. And often these patients will get chemotherapy, so you may want to stop all immunosuppression because it's just too dangerous to give the chemotherapy and also maintain the CNI. Interestingly, there was some data presented in Kidney International in 2013 from a French group that suggested maintaining the CNI was actually associated with better survival in PTLD because it was associated with less risk of rejection. And in that group, what they did was they withdrew the azathioprine or mycophenolate. There's been increasing interest in adoptive immunotherapy, so that's doing things like giving EBV-specific cytotoxic T lymphocytes as a strategy to managing PTLD. That's very much, in terms of solid organ transplantation, that's very much in its infancy, although that has been used more in stem cell transplantation. Secondly, you might want to get rid of the virus by giving antiviral drugs, such as acyclovir, but the evidence that this is efficacious is pretty limited. It's certainly in terms of treatment, because the virus, once it's in the B cells and the B cells become transformed, and the virus is relatively resistant to treatment, and it doesn't really have any impact, if you like, on the malignant transformation of the B cells. So giving antiviral drugs it certainly may help if you've got overt viremia in terms of controlling the virus, but it's probably too late in terms of causing the tumour to regress because the malignant transformation has already taken place. And then obviously you can remove neoplastic cells by giving chemotherapy. Evidence for Sirolimus and everolimus, again, is less clear. A lot of interest in rituximab, and there's some evidence for rituximab as both a treatment for established PTLD, but also increasingly emerging evidence to suggest that that it may be used to treat patients who are EBV positive who haven't yet developed PTLD. And you may want to remove the tumour, the lymph node. For example, if the tumour is within the transplanted kidney, then it may be necessary to remove the graft. So what's the evidence for reduction of immunosuppression? Well, this is just some data from the States, I think, looking at patients who've had immunosuppression, that's RI here, reduced compared to survival in patients who've had no change in their immunosuppression. And you can see that there is a strong tendency here for the patients who've had their immunosuppression reduced to have better survival. The median survival was 44 months compared to 9.5 months compared to those who were maintained on immunosuppression. And these patients had some, in the top line here, had surgery to remove the nodal mass after reducing immunosuppression. So good evidence, I think, for immunosuppression. A lot of observational data around rituximab. I'll just show you this phase 2 study, which is a phase 2 study of rituximab followed by CHOP, so chemotherapy in patients with PTLD. A very high response rate, 90%, and median survival rate of 6 years, which is pretty good post-transplantation. So this involved reducing immunosuppression, giving rituximab followed by chemotherapy. And this is a kind of multi-center retrospective analysis, again looking at PTLD post-transplantation in 80 patients. And they divided the survival up into, they did this analysis in 2 ways. They looked at overall survival and looked at those patients who got rituximab early on in the yellow, and those who didn't get rituximab early on, and those who got rituximab had better survival than those who didn't. That's progression-free survival and overall survival. And as I said earlier, there's increasing interest now in using rituximab to treat EBV viremia prior to developing PTLD, and there are some sort of small case series to suggest that that may be beneficial. But I have to say that's quite speculative data at the moment, and the data is small. So summary, what do we say about PTLD? The risks are really associated with the immunosuppressive load and particular lymphocyte depleting treatments such as ATG and AKT3 or co-stimulatory blockade. EBV monitoring in seropositive patients as a preventative strategy is unclear, but if you're seronegative at the time of transplantation, it may be more useful. And the mainstay of management is really reduction in immunosuppression, rituximab, chemotherapy and radiotherapy as advised by the hematologist, and adoptive immunotherapy with cytotoxic EBV-specific T lymphocytes is a sort of emerging area of interest and may be a new therapy that emerges in the future. Okay, finally I'm just going to talk a little bit about skin disease. Skin disease is common after transplantation and can account in some cases about 40% of malignancies post-transplantation. Very common in the Caucasian population, and you get a range of lesions including basal cell cancer, squamous cell cancers, melanomas and Kaposis sarcoma. And really again this is an impaired immune surveillance causing proliferation of cells with viral, perhaps with viral, as a result of viral transformation of cells. So just some pictures I just downloaded from Up to Date, just to show you what some of these lesions look like. There's actinic keratosis, which is quite common after transplantation, which is can be a form of squamous cell cancer. There's an established squamous cell cancer on the dorsum of someone's hand. That's a classic basal cell cancer on patient's nose. That's a Merkel cell cancer, which has got this sort of nodular appearance, and that's a Kaposis sarcoma. Again, not so commonly seen in Northern Europe, but much more common in the Mediterranean and Middle East. And we look at the effect of different immunosuppressants on the skin. They're really summarised here. I'm not going to read them all out for you because you can pause the slide here if you want to read the slide. But what this table nicely summarises is the sort of, if you like, the dermatological side effects of the drugs and the risk of non-melanoma skin cancer associated with the treatment. And as you can see, Tacrolimus, Cyclosporin, Mycophenolate Islatharin, all associated with an increased risk of skin cancer. What are the risks of skin cancer? Well, age, the amount of sunlight you're exposed to, UV radiation, the skin type, so fairer skin much more likely to get skin cancer than those who aren't fair skin, the intensity and duration of immunosuppression, people who've had a past history of skin cancer, and geography is important, so where you live, people in Australia, where perhaps it's sunnier, more likely, and there's more UV, are more likely to get more UV exposure than in places in perhaps patients in Northern Europe. And you can see that here, and this shows quite nicely the impact of both geography and time on the development of skin cancer. You can see with time the number of skin cancers increase, presumably just reflecting cumulative immunosuppressive load. This is data from the collaborative transplant study, but also you can see that it's much more common in Australia than it is in Northern America, Southern America and Europe. This slide just summarises an approach to managing skin cancer in terms of how you should, how often you should examine patients' skin and how often they should be looked at, and it's all based on risk stratification. I'm not going to read that slide out for you. I think it's fairly self-explanatory. Again, you can just press the pause button and look at that in more detail if you want to. If I just go on to the next slide, this slide summarises the treatment for each of the individual types of skin cancers, whether they're the actinic keratoses, invasive soil carcinoma, basal cell cancers. The treatment is really as in the normal, as in the non-transplant patients, and really you need to get advice from the dermatologist as to how they want to manage that. What I'm going to do is just spend a bit of time talking about sirolimus and skin cancer because this is an area of huge interest. So sirolimus and everolimus are mTOR inhibitors, and the mTOR stands for mammalian target of rapamycin, and the mammalian target rapamycin signaling pathway is really central to cell proliferation. And there's a lot of in vitro and in vivo evidence that mTOR inhibits tumour growth. I think it's fair to say there's poor evidence that sirolimus is efficacious in melanoma and in basal cell cancers, but there is some quite good evidence that sirolimus has got significant anti-tumour activity in those with squamous cell cancers and those at risk of squamous cell cancer. So if we look at this study here, which looked at 86 transplant patients with a history of non-melanoma skin cancer, patients were either randomised to continue the calcineurin inhibitor or switch to sirolimus. And you can see that the new lesions were significantly less likely to develop in the sirolimus group, that's the black dots here on the top, compared to the CNI group. But the problem with sirolimus is that many people can't tolerate it. And in most clinical studies, around 30 to 40% of people just cannot take the drug. And in this particular study, it was a very high discontinuation rate of 46%. So it works. You can switch people to sirolimus, but you've got a 1 in 3 or 1 in 2 chance nearly of not tolerating the drug. Of course, if you've got proteinuria, you can't switch somebody to sirolimus. And if you're switching somebody late to sirolimus, that with abnormal kidney function, that may worsen graft function as well. So sirolimus has certain certainly is good has a good effect on skin tumours, but switching people to sirolimus isn't straightforward. This study that was published in the New England Journal a few years ago looked at secondary prevention of squamous cell cancers. So these are 120 transplant patients who were randomised to sirolimus or to continue the CNIs. And what you can see is that in the blue line here, overall in all patients, there was a significant reduction in the development of new squamous cell cancers, and that's the sirolimus group there compared to the calcineurin inhibitor group. These are patients who developed just one single cancer, squamous cell cancer, and these are the patients who developed more than one. The significant difference was really driven by this group here who developed just one single squamous cancer. It had more than one squamous cancer. The difference wasn't so clear. But the discontinuation rate was really high in this study, and again there was a very high, a much higher rate of serious adverse events. So it does, if you can tolerate it, it will help your skin, but the effects are somewhat mitigated by the high dropout rate and poor adherence, and certainly there was the evidence that it's helpful in, say, basal cancers is really not there. What about Kaposis sarcoma? Well, there is some evidence that sirolimus is efficacious in Kaposis sarcoma. You can see from this publication published in the journal a few years ago. The patient gets some sirolimus, Kaposis sarcoma starts to melt away quite soon after starting the sirolimus. And in this paper, they looked at 15 patients with Kaposis who were switched from cyclosporin A to sirolimus. The graft function remained stable, and there was clinical and histological resolution of all the lesions, and they actually did repeat biopsies. And what they showed was that there was when they did skin biopsies, and there was evidence of upregulation of the signalling pathways that were targeted by sirolimus. So for an example of that, here this is staining for VEGF, so vascular endothelial growth factor. That's in normal skin. That's in people with Kaposis sarcoma. You can see the big upregulation, and then after you've been given rapamycin, that's upregulation is inhibited. And there's upregulation of other signaling proteins in Kaposis, such as phosphate AKT, which is a protein from the PI3 kinase pathway, which is a survival protein, so it's an anti-apoptotic protein, and P70S6 kinase, which is another enzyme inhibited by sirolimus. So there are a number of enzymes that are inhibited by sirolimus that are upregulated in Kaposis, and seem to be inhibited by sirolimus. Okay, so I'm just going to conclude now. So just what did I say? Cancer risk is increased in patients with immunosuppression. Skin surveillance is important, and monitoring EBV in patients at high risk is important for preventing PTLD. But treatment really centres around reducing immunosuppression, maybe perhaps using sirolimus for patients with squamous cell cancers, and treating the underlying virus and cancer. There's absolutely no proven role for routine screening for cancer such as prostate cancer, etc. Thank you very much for your attention.